Pancreatic cancer has been a lethal malignancy for too long. Available cytotoxic therapies for advanced disease are modestly effective, with a 5-year survival rate less than 15%. But new modalities using ablative radiation therapy holds promise in improving outcomes. Reports of ablative radiation therapy for pancreatic cancer using a 0.35 Tesla MR-Linac have resulted in promising local control and overall survival, with no severe toxicity in patients with locally advanced pancreatic cancer, despite radiosensitive organs being adjacent to the target volumes. Global testing has found a wide variation in the treatment planning protocols for pancreatic tumors with this MR-guided SBRT approach with a 0.35 Tesla MR-Linac system.
Welcome to the Baptist Health Doc to Doc podcast, a conversation for physicians by physicians, providing insight on the latest in medical practice, research, technology, and innovation in healthcare on the Doc to Doc podcast.
Hello, I'm Dr. Mittauer, a board-certified medical physicist with Baptist Health Miami Cancer Institute, an associate professor at Florida International University, Herbert, Wertheim College of Medicine. And joining us for the discussion is Dr. Adil Kaiser, a board-certified radiation oncologist at Baptist Health Miami Cancer Institute and clinical associate professor at Florida International University, Herbert Wertheim College of Medicine. So, Adil, we have a couple points we would like to talk about with the MR-guided radiation therapy. Can you start us off today just overviewing MR-Linac treatments and discussing the details of what we do on a daily basis?
All right, thanks, Kate. I think this is going to be a great discussion. So MR-guided radiation therapy has been a real game changer in terms of what we can offer our pancreatic cancer patients. Just to kind of give a real quick overview, prior to MR-guided treatment, we had severe limitations in the doses that we could give to our pancreatic patients. As a consequence of that, outcomes were very poor. So if you looked at the studies that predated those with MR-Linac, those studies really showed survivals of in the 20 to maybe 30% range. And then there was a landmark study that was done at MD Anderson that showed that if you could get higher doses in, could actually improve 2-year survival. And I know that sounds like a small number, 2-year survival, but that's the metric we're stuck with at the moment. But that 2-year survival now could be improved from about a quarter to 1/3. However, most patients cannot get that higher dose of radiation safely because a lot of times the pancreatic tumor is stuck adjacent to critical organs, such as the GI tract luminal structures, namely the duodenum or the small bowel. So with MR-guided radiation therapy, now we have the capability to actually safely deliver high doses of radiation to those tumors. As a consequence of that, we have seen our survival numbers improve. And with the latest SMART data that was just published, SMART, of course, is the trial that was done at multiple centers across the United States where MR-guided radiation therapy was used in pancreatic cancer patients. And in that study, 2-year survival was improved by over 50%. So that's a huge jump compared to what we could do previously. So number one, MR-guided radiation therapy has really changed the landscape. And as far as what we do on a day-to-day basis, we try to select patients who we think could optimally benefit from that treatment. That trial that I had mentioned earlier was restricted to locally advanced patients. But we also will see patients who are borderline for surgery, and we also leverage this technology in those cases as well. So at least at Baptist, at Miami Cancer Institute, we have now essentially transitioned the majority of our pancreatic cancer patients that are receiving radiation therapy to an MR-guided approach.
And so you talk about that first landmark trial that brought us up to 1/3, the 2-year survival up to 1/3.
Half, actually.
Half, but going back to the MD Anderson trial.
Oh, right.
Anything different in terms of the approach that they use, how they selected patients versus how we're selecting patients for MR-guided radiation therapy, in terms of geometry and patient selection?
Okay, great question. So as I kind of alluded to earlier, that dose escalation that they were able to do at MD Anderson was restricted to patients with favorable anatomy. So favorable anatomy means the patients had tumors that were at least a centimeter or more away from those radiosensitive luminal structures like the small bowel and the duodenum or stomach. So obviously, that's going to restrict who we can offer high dose radiation therapy to. And that's really where MR guided treatment comes in, because thankfully, with MR guidance and with daily adaptive radiotherapy, we can adjust for the positioning of these critical radiosensitive structures and safely deliver high dose radiation, just like they did in the MD Anderson study, but now for a wider group of patients.
Exactly. And so would you say that we have a positional difference between the small bowel duodenum versus the tumor geometry? Do we have a limit in terms of the proximity for our patients that we're treating at Miami Cancer Institute? Or now it's completely open when we have a budding geometry that we can treat those patients now?
Right. So pretty much we can treat any patient, even if the tumor is right up against those critical structures. However, if the tumor has already progressed to the point where it's invaded into the duodenum or the small bowel or the stomach, then those patients are not a great candidate for dose escalation with MR-guided radiotherapy. So we may still use the technology, but we do have to adjust the dose down a little bit, because if you have invasion into those structures already, the concern is, believe it or not, that you could get such a robust response to the treatment and regression of the tumor that it actually leaves a hole behind where the tumor had invaded into the
Sure.
stomach or bowel.
Yeah. And I think this kind of leads into some of the dosimetric advantages that we can offer patients with MR-guided radiotherapy. So, as you know, we put the patient on the table and we create an adaptive radiotherapy plan based on the patient's geometry of the day. And really, for pancreatic cancer, geometry is the name of the game. So, in terms of dosimetric advantages or just overall dosimetry, what are your thoughts as the treating physician on MR-guided radiotherapy for pancreatic cancer patients?
Right. So we know that the bowel and the stomach move around. It's well established even in studies before the MR-guided radiation era, from just CT imaging. You can see that the stomach, the small bowel are fluid in terms of their respective location relative to the pancreas and the pancreatic tumor. Okay, so that has always been a challenge. Now, with MR guidance, we use a new image every session that we do the treatment. And typically, the primary regimen we use is a 5-session approach. Again, patient is re-imaged before each one. And then at that point, we redraw our targets, because the targets themselves could also be slightly in a different position than they were on a prior day or the simulation scan. Once we do that, then we focus on all the normal organs at risk. Those are outlined in their new position that day. And then at that point, we kind of turn it over to you, Kate, to do the magic that you do with replanning to re-optimize the radiation dose. So hopefully you can give us a little bit more detail.
So at Miami Cancer Institute, we evaluated for the plan quality. An important part is the robustness of the plan quality of the adaptive plan. So we actually looked at taking, the plan quality between the initial plans done on the simulation anatomy and comparing that to the adaptive plan quality. And we wrote this up recently in Green Journal. So looking at the plan quality, we found that we have equivalent plan quality for that on-table adaptive that's done in 20 minutes compared to that initial plan that's done over an 8-day roughly care path. So this is exciting to see in terms of equivalent plan quality for our program. So kind of moving on from kind of the dosimetry and plan quality of things and talking about more of the technology side of what MR-guided radiation therapy, gives us in terms of imaging and tracking opportunities. So most of these patients are done in a breath hold approach. There's advantages there because we're able to visualize the GI luminal walls based on a breath hold scan. So there's no blurring effect from respiratory motion. We're also enabled to eliminate an ITV approach. So our margins are actually simply just a 3 mm expansion from the GTV to the PTV. So what else in terms of, imaging that kind of sets us apart for these patients for pancreatic cancer with MR-guided radiotherapy compared to what we're doing on conventional CT-based technologies, would you say is advantageous for these patients?
Right. So I think what we've talked about right now is just the setup of the patient, how the anatomy differs day to day, and how we account for it, right? We redraw, and that's done by the physician directly. So if it's not me, it's one of the covering physicians who's accredited to actually do MR cases. And then as we just discussed, the physicists take over, optimize the plan to give the hot spot, meaning the high dose area of radiation right to the tumor, limit it to the normal OARs. And then the next step, of course, is to deliver the dose. And I think one thing that really sets apart this technology is another feature, which is tracking, right? So we can actually track the radiation target, and we actually will leverage the patient's feedback on this. So the patient is actually shown an outline of a structure, which really corresponds to the tumor target, and another circle that corresponds to where they are in their respiratory cycle. Because, of course, the positioning of the tumor can change depending on how deep they are in the respiratory cycle, whether they're in exhale or inhale. We want them to be in an inhale approach, but we also want it to be inhaled at just the right spot so that those two structures overlap, which is a visual cue that the patients have to hold their breath at that specific spot, and then the radiation dose is delivered. So, Kate, I think you can comment a little bit more on what you, as a physicist, look at to make sure that this is done in a very robust and reproducible and safe manner.
Yeah, absolutely. So, what you started off with saying is, this is a game changer. So, the MR imaging is soft tissue imaging. I mean, it's really enabling us to see the visualization we need for pancreatic cancer patients. It's also doing it without any extra imaging dose so that we can actually image the tumor directly. We're no longer using fiducials, so we don't have to do any implantation of fiducials because we're able to track the tumor directly. So when we're tracking these patients, we have a couple of different techniques we do. We can do multiplanar tracking, which means we're visualizing the tumor in both the sagittal and coronal orientation. And we're able to watch not only the tumor itself, but also those GI luminal structures that are radiosensitive and what we've just created this beautiful adaptive plan based on. So making sure that the tumor's in the same location, but also these GI luminal structures are in the same location when we are going to do the delivery of that adaptive plan. So where things we're looking at are, patient compliance, repeating that breath hold. They don't have to hold it very long. We're giving our patients oxygen. A lot of our patients are enjoying having supplemental oxygen to be able to increase their breath hold duration and reproducibility. It's just a comfortable breath hold, as you said, a very shallow, comfortable breath hold. So during the tracking, we're watching the deformation of that tracking structure, which is the tumor itself, and making sure that that's done appropriately. So as a physicist covering, we're making sure that's being done accurately. And we're able to make changes during the delivery. If the GI luminal organs are actually moving, then we can simply pause, re-3D, and shift them in an appropriate location. Or if we need to do a further adaptation, you and I will make that decision together. So in terms of the delivery and tracking, I think it goes hand in hand with the ablative dose, right? We're able to, because we're able to track the tumor directly and watch the GI luminal structures during the whole treatment delivery at 4 or 8 frames per second. So it's a very rapid imaging session that we can control, really visualizing these internal radiosensitive organs and be able to deliver this high dose that we did during the adaptive plan. I think MR-guided radiotherapy is really giving a lot of advantage with the soft tissue visualization and the tracking without, extra radiation dose. So, and moving on to, I think you and I appreciate how much anatomy changes. We see this every day in our pancreatic patients. But, there's the MD Anderson study did not use adaptive radiotherapy and didn't create a new personalized plan every day the patient was on the table. How much does the anatomy move? Do you really need to adapt every day for a 50 gray prescription pancreatic patient? What can you give me your insights on that?
Yeah, so there's been a few studies looking at this, right, where they kind of looked at how much the anatomy has moved and required the adaptive therapy that we do. And if you look at the data, usually you're looking at about 80 to 90% of the patient's treatment sessions requiring adaptive therapy. So pretty much the majority. It's rare not to require adaptive treatment. And so that's why this 5-session high-dose approach is really confined to centers that have MR capability. If you don't have this, it's really just not a safe strategy. So one thing that other places may do is do a longer treatment course, which of course just means more time for the patient in the hospital, more time in the system. But that's the only way to deliver a safer dose using standard radiation treatments. So by giving a smaller dose per day. We have done some studies with collaboration on some of the centers like Memorial Sloan Kettering. And if you look at the data, it does suggest that perhaps even with the increased fractionation and the safety of that higher dose using that methodology, that results are still better using the 5-session approach. So I think ultimately, if you're given the choice and you have the capability of doing both like we do, we're going to choose, of course, MR-guided radiotherapy, both because it's faster, less sessions for the patient, and also results are slightly better as well. And then the other thing that we sometimes consider for patients is, and you're alluding to this is, okay, well, how much does the anatomy change? And we ourselves define that better. So we ourselves did a study that was presented, and now we're writing up the final paper for, which is comparing CT and MR-guided radiation therapy very, very directly. So what we did in this study is actually looked at the patients who we'd already treated with MR guidance, and we basically used their anatomy of the day and layered on a CT-based radiation plan. And as the abstract indicated, there was clear violation of normal organ tissue constraints, meaning that we exceeded the amount of radiation dose that's safe for those organs if we used a CT-based approach. So both our data as well as data from other centers suggest that really, the only way to do a 5-session ablative dose safely is with MR guidance. You have to do other things to make to get the same effect using standard machines. And again, that you could say approach with increased fractionation may not be as successful.
Yeah, I agree. In that study with the CT plans that we did, they were actually VMAT, which is more sophisticated than what we're doing with MR-guided, which is IMRT. But, just because the VMAT plan quality, you have arguably maybe sharper fall off. As you said, the organs at risk were still violated with that study. And we used the same margin. We used a breath hold approach. We simulated a breath hold approach with the CT guided arm. So even with the 3 millimeter arm head to head between the VMAT and MR guided, still demonstrating the advantages of having to do adaptive radiotherapy in that study. So kind of moving on to some of our other work, particularly the SMART trial, and then also our own institutional data. What are we seeing in terms of toxicities for these patients, specifically GI toxicities? And then overall, I know we talked about this earlier, but, give us a better sense of the outcomes for these patients that we're treating.
Okay, so let's talk about the toxicities first, because, even with the best technology, careful patient selection, very good rigor, there's going to be some patients that have side effects. When you're pushing the limits like we are, you're going to have certain cases like that. So even though overall the rate of serious toxicities is probably under 5%, you look at the data, we do see some of those. And the ones we see are, maybe injury to the bowel, can also have obstruction because you can get scar tissue development in the stomach area. So sometimes patients can have increased difficulty passing food. That one is at least more easily solved. Sometimes you can put in a stent. Other times that obstruction may resolve on its own. Serious injuries that are life-threatening, like a bleed in an artery, are very rare, but we have seen them. So patients do have to be consented that there is still a possibility of seeing these side effects. And by the way, these side effects are still seen even in patients that get lower doses of radiation. So what we're proud of is the fact that even though we're going to much higher doses, we're seeing radiation toxicities at or even below the levels of those seen in patients getting lower doses. Now, in terms of pushing the limits now for these patients, one point that you had mentioned earlier was that we're trying to improve our results by also treating a bigger area around the pancreas, which is the nodal area. So pancreatic cancer can spread through the lymph nodes. And we have lots of data examining that fact. It's really not disputable at this point. And so one thing that we've done is not only given these patients now high dose to the pancreatic tumor, but a slightly lower dose to all the lymph nodes that could be at risk of spread. And our feeling is that by doing this, we're going to have better results, better what we call local control, regional control, meaning that the patients will have less chance of relapse in this area because we've irradiated electively. If you look at the SMART trial data and our data, the results show that the local control rates are in the 75% range, meaning that the tumor is only 1/4 of a chance that it may recur in the area that we irradiate. However, survival is still just 50%. So what does that mean? That means that patients are failing outside of the radiation area. So we're also trying to push the boundaries on that. My colleague, Dr. Chung, is the PI of a trial that he wrote looking at the addition of tumor treatment fields to the patients after they've received MR-guided ablative radiation. So the patients get the MR-guided treatment, and then they get basically electrical fields that are placed on their abdomen to reduce the risk of cancer recurrence, especially in the liver or the rest of the abdominal cavity, which tends to be the area where patients fail the most. So that's an exciting trial. It's still ongoing. So obviously we don't know the results. I can't report anything like that yet. Right. But of course we hope that it's going to reduce the risk of recurrences. The patients obviously have to be invested in this because they have to wear kind of like an array yes. Yep. Around their abdomen, and they have to do it on a day-to-day basis.
Fantastic. And then just to report, we love our prospective data in terms of toxicities. The SMART trial data, of course, showed for grade 3 or higher GI toxicities due to radiation was actually 0%. So that was in that multi-institutional setting with MR-guided radiotherapy of a prescription of 50 gray and 5 fractions that we demonstrated a 0% grade 3 toxicity. So kind of to wrap up in terms of short course opportunities for patients, you talked about 5 fraction, the advantages of that. What do we have in terms of maybe evidence of going to an ultra hypofractionation regimen? Maybe speak a little bit about the SMART-1 trial that we've done at MCI.
Yeah, so the SMART-1 trial, I think, is obviously a step to push the limit even further. But that trial also is really looking more at metastases. So we're looking at patients who potentially have progressed, may have metastasis in different organs. And this is not restricted just to pancreatic cancer patients necessarily, but other patients who have different malignancies, unfortunately, may progress after their surgery or their radiation. And the question is, how do we best manage their metastases and do it in a very efficient manner? Because at the end of the day, when you have a patient with metastatic cancer, the main therapy is drug therapy, right? They have to be continued on systemic treatment that goes all over their body. And you don't want to interrupt that as much as you can. You want to just focus any local therapy in a short amount of time so that, you don't have any interruption to their drug therapy. So that's kind of the main idea behind the SMART-1 trial. We want to give ablative doses to areas that may not be responding to the drug therapy. Okay, so a lot of times patients have what we call a mixed response or heterogeneous response treatment, where one area of metastasis is responding beautifully. It's not growing or maybe even dying or dead, but other areas of metastases may not be responding to that same drug regimen. The presumption is that there's slightly different mutations in these different metastases that cause a differential response. And so what we're trying to do is radiate those areas so that the patient can maintain treatment on the same line of chemotherapy, because there's unfortunately only a certain amount of chemo drugs that are available. And we want to really milk as much as we can in terms of benefit out of each one. So the main aim of this of the trial was, let's do this radiation as fast as possible, as safely as possible, with the goal of getting ablative therapy to eradicate that area of tumor deposit. And that result My colleague, again, Dr. Chung, who's really been instrumental in all of these studies,
Absolutely.
Recently presented that at a national meeting, and it was very well received. Local control rates were extremely high, and including local control for tumors that tend to be sometimes, quote unquote, radio resistant. So we were really excited about those results.
Absolutely. And pancreatic patients were actually it was a diverse selection of patients, and pancreatic patients were a part of that. So definitely exciting work led by Dr. Chung. So in conclusion, the outcomes of MR-Linac show that treatment is not only highly accurate at targeting small tumors, but also minimizing damage to surrounding tissue. Though still in early stages, the treatment has revealed improved survival rates for many pancreatic cancer patients. The novel treatment also shows great promise for treating a variety of solid tumors, as well as helps avoid the high risk of reoccurrence from surgery alone. The future looks promising as precision-targeted treatments using MR-Linac sidelines many of the limitations from conventional radiotherapy. Thank you, Dr. Kaiser, for your time today.
Thank you, Dr. Mittauer.
To find out more about the topics covered on the Doc to Doc podcast, please visit physicianresources.baptisthealth.net.